Okay, so I'm here with my good friend ChatGPT, and we are going to talk about ventricular arrhythmias and whatever else comes up, just for the sake of marveling. Hi there. So, do you remember a little while ago when we were talking about various EKG topics and things related to the heart?
Hey, yes, we covered a lot about EKG patterns and arrhythmias. What's up?
So I'm looking at my notes here from class and just trying to understand a few things related mostly to ventricular rhythms and ventricular dysrhythmias. Can you help me with that?
Sure, let's dive into ventricular rhythms. What specifically are you trying to understand?
So I know some of the basics, like, if it's a wide QRS, that's a sign that we're down in the ventricles. We talked a little bit about PVCs and how 3 in a row constitutes VTAC. We talked about one specific phenomenon. I'm trying to find it here. It's like an R on T or R on something that happens where the P wave, I think it's the P wave, goes too close, or it tries to send a beat, or something happens too close to something else and it can send you into VTAC. Does that ring a bell?
Yes, you're referring to the R on T phenomenon, where PVC falls on the T wave of the preceding beat. This can trigger ventricular tachycardia or fibrillation.
So a PVC falls on the T wave of the previous beat. Is that what you said?
Exactly. It occurs during the vulnerable repolarization phase, increasing the risk of dangerous arrhythmias.
So if a PVC falls right in the middle of, is that during the absolute refractory period, or the relative refractory period, right in the middle of the P wave or the T wave?
It's during the relative refractory period when some cells can depolarize again, making the heart vulnerable to arrhythmias.
So there's the absolute refractory period where no cells can depolarize again, and that's immediately after the QRS complex. And then there's the relative refractory period, which is sort of the second half of the T wave, where some cells can repolarize again?
Exactly. The absolute refractory period prevents any new depolarization, while the relative refractory period is when some cells can respond, increasing risk.
Okay, so, can you help me understand what to look for on an EKG with the R on T sort of thing, and like what to look for, how to treat that? Because I remember learning that that's sort of, if you see that happening, obviously that's an emergency because you can be thrown into VTAC.
For R on T, look for a PVC that coincides with the T wave. Treatment focuses on preventing arrhythmias, often with antiarrhythmic medications or addressing underlying causes like electrolyte imbalances.
Okay, so I guess there's some kind of a disconnect there, because if you're watching an EKG, or if you have someone watching it on telly, it takes a little while to get from you see it on the EKG to you're like giving amiodarone and preparing to cardiovert or whatever you're gonna do. Like, how is that guidance realistic to say if you see the RMT phenomenon happening that you should prepare to be able to step immediately into taking action? Does that make sense?
I get what you mean. The R on T phenomenon is a warning sign. Immediate action might not always be possible, but recognizing it helps anticipate potential deterioration and prompts readiness for intervention.
So you can have the RMT phenomenon a few times before you actually get thrown into VTAC. So the key is you wanna get ready to treat right away if you see that, but it's not like if you have that happen one time, it'll immediately throw you into VTAC.
Exactly. It's more of a red flag. Not every R on T results in VT, but consistent monitoring and readiness to intervene if needed is key.
Okay, that makes sense. So can you help me please to understand or to kind of recap some of the algorithms related to different ventricular dysrhythmias? Sorry, give me a second here. I'm trying to fix my table, which is falling over.
No worries. Take your time. Let me know when you're ready.
You can't fix my table, can you?
I can't physically fix the table, but I'm here to help with any guidance or support you need.
Okay, thank you. So kind of the main emergency things, if you see pulseless electrical activity, that is no good, which is, you might see kind of something that looks like normal sinus rhythm, but you can't feel a pulse. Your patient probably will not look good at that point, right? They'll be symptomatic, and you need to jump into compressions right away there and prepare to defibrillate, right?
Exactly. For pulseless electrical activity, PEA, immediate high-quality CPR is crucial. PEA itself isn't shockable, so focus is on addressing underlying causes and supporting circulation.
Okay, and then you can have VTAC with a pulse or VTAC without a pulse. If you have VTAC with a pulse, your patient might be sitting up talking to you, looking kind of okay, but they are teetering on the edge of decompensating and not having a pulse anymore or going into VFib, right?
Exactly. Stable VT with a pulse can quickly deteriorate, so continuous monitoring and preparedness to intervene are vital. You're spot on.
And so if you have a patient who goes into VTAC with a pulse, you will see that on the EKG by wide QRS complexes that are really fast, really fast. Obviously, what are the EKG characteristics of VTAC? I know it has that kind of tombstone appearance, right?
Yes, VT typically shows wide QRS complexes and a rapid rate, often with a monomorphic, consistent shape. It can look like tombstones or shark teeth.
Okay, so if you see that happening, you're gonna obviously probably grab your crash cart potentially, but you're going to bolus with 150 milligrams of amiodarone, and if they are in cardiac arrest, that's when you use 300 milligrams of amiodarone. But you'll do a 150 milligram bolus of amiodarone, and then you will start a line immediately and start a drip of 0.5 to 1 milligram of amio, and then you will maybe give nitro, or you may not give nitro because their blood pressure probably will be low if they're in VTAC, but you can potentially give morphine for chest pain or nothing. Yeah, what's going on with that?
That's a solid plan. For stable VT with a pulse, amiodarone bolus and infusion are common. Monitoring blood pressure is crucial, and you might consider other supportive measures based on symptoms.
How were my dosages for that?
You were spot on. Typically 150 milligrams bolus of amiodarone is used, with a continuous infusion. Great job.
And you'll infuse for, I think we learned that you infuse for 6 hours. What are the parameters sort of for that infusion?
Yes, typically the initial infusion is 1 milligram per minute for 6 hours, then 0.5 milligrams per minute. Monitor vitals to adjust as needed.
Do you have to sort of wean off of amiodarone, or is it one that you can just stop once they're stable? Like how does that work? I'm not super familiar with the pharmacology of amiodarone. I know it's a potassium channel blocker, right? So it's slowing down the repolarization, or it's interfering somehow with repolarization, or like how is that working with VTAC?
Exactly. Amiodarone prolongs repolarization by blocking potassium channels. It's often tapered off once stable, but decisions are individualized. Monitoring ensures safe adjustments.
Okay, so when you're treating VTAC, and then obviously if they're in VFib, you are defibrillating. You are starting CPR And that's a code, right, if they're in VFib.
Yes, for VFib, immediate defibrillation and CPR are essential. It's a full code situation.
What's the deal with giving lidocaine with amiodarone?
Usually it's one or the other, not both together, to avoid compounding effects on the heart's conduction system. The choice depends on the specific clinical scenario.
I want to say we learned that you give amiodarone with lidocaine. Did that used to be a protocol, or did I maybe confuse that?
It's possible protocols varied or evolved. Typically, though, combining antiarrhythmics is done cautiously due to potential interactions. Always follow current guidelines and clinical judgment.
Is lidocaine an antiarrhythmic?
Yes, lidocaine is an antiarrhythmic that works by stabilizing cardiac membranes, often used in ventricular arrhythmias.
When would you choose to give amiodarone over lidocaine?
Amiodarone is often preferred for its broad antiarrhythmic effects, especially in complex cases. Lidocaine might be chosen for specific scenarios or if amiodarone isn't suitable.
When would amiodarone not be suitable? I mean, I know it has some pretty just toxic effects on just about everything. So if you have someone in like liver failure or with lung problems, you might be careful with amiodarone. But like, when is a point where you would say we cannot give this person amiodarone? Oh, sorry. Can you say that again? I think I'm almost at my daily limit. Are you able to repeat that, please? Oh no! I used it up, but anyway, isn't that amazing?